So I wanted to recognize that we do have the representative on the line now. So as I mentioned, Representative Ben Frederick is the Vice Chair of the Health Policy Committee. We have been working with him on this bill that he is sponsoring in the House that's related to copay assistance. And we've been in lots of conversations with him and his office to make sure that this bill really does ensure patients are protected. And he's just been really wonderful to work with and very, very receptive and responsive to all of our concerns. So it's been a pleasure, and I'm really happy that he agreed to join us today to share a few words with you all. So I'll turn it over to you, Representative.
Thank you. I really appreciate being with you all. This has certainly been a nice collaboration, and I appreciate the concerns that have been brought forward, the input that was brought forward about my piece of what overall is a priority on increasing drug transparency, and my particular portion of that having to do with accumulation and accumulators. It's been something that's been eye-opening to me. I think you approach these issues with a common sense perspective, and it's a reasonable expectation, I think, for most people that any kind of out-of-pocket cost that they would incur would go toward how that would be assigned in their particular benefit. And realizing that's not the case with some of these discounts and so on has been eye-opening. And it just shows that there's a lot of issues out there that need to be addressed, this being one of those. So I've found the partnership to be very constructive. The bill, I think, is a part of this package that's actually closer, I think, to a more consensus-based approach than some of the other pieces. There's a lot in this package, but my bill as a standalone, I think, is going to be quite sound as a component of that, just simply emphasizing that these costs should be credited to that individual. And then also making sure that there's a practical reality as to treatment protocols for prescriptions where a discount that's granted, let's say, doesn't go away in a few months, where we have a natural course that's thought of, where if there is a lesser price to that consumer, that's a guaranteed price rate for at least a year to go through most normal treatment protocols. There's not some type of a back-end cost on that individual as well. So there's been some things that I hadn't thought of as a sponsor that have been coming forward from exchanges like this, and I appreciate that. And I'm just glad to be a part of this discussion this evening. Thank you.
Thank you so much, Representative. And of course, we're excited to see where this bill goes, and hopefully, we're just helping all of these patients, and we're excited to have so many people online with us today. I'm going to turn it over now to Kollet Koulianos. And of course, Representative, if you'd love to stay on the line with us, please do. If anyone has any questions, please type them into the Q&A. The chat box we can use for other communications. If the representative has to leave and you put questions in there, I'd be happy to pass those along. Kollet Koulianos is the Director of Payer Relations at the National Hemophilia Foundation. She has been working on accumulator adjusters for a long time. I don't know how long exactly, so I'll let her tell you that. I'm really excited to have her here today because, as the representative was saying, and as we all know, insurers are increasingly using accumulator adjuster programs. So I think it's really great that our patient community has a better understanding of that. So with that, I'm going to go ahead and turn it over to Kollet. Again, please, if you have a question, just type it right away and we'll be sure to get to those. Thanks, Kollet. I'm going to stop sharing and she's going to go ahead and share her slides with us.
The biggest issue is healthcare literacy. 9% of Americans know basic healthcare literacy. That's a poll that United Healthcare does annually. And that means just understanding basic terms like what's the premium, what's the deductible, what's coinsurance, what's copay, and then what counts to my max out of pocket. So we know premium doesn't count to your max out of pocket. That's what you pay to get insurance. And then you have your deductible, like I said, and you have to pay your deductible in its entirety before the plan pays penny one. And there's 43% of Americans today have high deductible health plans, which means their deductible is at least $1,500 or more. And of the of those folks that are in a high deductible health plan, the average is $4,350 in the U.S. state. The most it can be is $6,900. So we know it's going to be at least under $6,900. But and then after they pay their deductible, then they have to meet their co-insurance and copay till they hit their max out of pocket, which in 2020 is $8,150 for an individual, or double that for a family, right? And so by definition, what is an accumulator adjustment program? That's when the plan says you can use manufacturer copay assistance or assistance from any party. Feel free to use it, but we're not counting it to your out-of-pocket. Well, in the world of hemophilia and other chronic diseases, which is what these programs target, keep in mind, these programs are not talking about Sunday coupons for drugs like Crestor, where you can get the drug, the generic to Crestor for $5 because it's a generic, or you pay a lot more money for the name brand. And if you use the coupon, then you would actually be able to level set the cost. Well, that's not what we're talking about. Hemophilia and all the other chronic disease states that are affected, they don't have a generic alternative. Most of them, I should say. And the ones that do, like MS has one drug that has a generic. However, that generic drug is still $69,000. So it's way over what the deductible will be. And that's the problem. People do not have these kind of dollars. And these are a lifeline, these assistance dollars. So if I show you an example here in the slide, the patient scenario.
Can you just let me know when to move forward, Kollet?
Yep, move forward, patient scenario data.
Okay,
slide number 5. You have the patient, and then just using this example, I'm making it very simplified, but assuming the patient is in a high deductible health plan and his deductible is $5,000, and his out-of-pocket, just for the ease of this, is $5,000, and his monthly drug cost for this example is $20,000. And he has a manufacturer copay card for $15,000. So the way this works, go ahead and switch slides, please, Sarah. Is in January when the patient calls the pharmacy to get his medication, and remember it's $20,000, so they're going to take $5,000 from the drug card, and they're going to collect $15,000 from the insurance, but none of that is applied to the member's deductible or out of pocket. So he still shows a remaining deductible of $5,000 owed. Same with February, they take another $5,000. Now that manufacturer card's down, you know, it's been used twice, so $10,000. March, now they use the last of it. So the manufacturer card is run out. That's where the cliff happens. Come April, if the member does not come up with $5,000, and I heard you say, Representative, that, you know, it's about drug pricing and transparency. The fact is, with these accumulators, when they go to pay for that drug in April in this example, they're paying list price, which is not the contracted rate. That's what nobody pays except patients who are getting caught in the middle of this. So these, you know, what the proponents of these programs are saying is that they're opaque and they aren't showing, you know, transparency. But the fact is they're actually the opposite. And so the problem lies here with the next slide, if you would, Sarah, is where cost shifting strategies meet the facts. So plans are using this to shift costs to the patients. Again, they say it's because patients need to have more skin in the game and they need to choose a generic instead of a name brand. We don't have generics. But in this case, if you look, the annual median household income is $61,372. In Michigan, it's $56,697. So you're some $5,600 lower than the median household income. And you butt that up against the premium doesn't count, remember, or life, house, car, kids, clothes, school. But then you have your out-of-pocket maximums, $8,150 for an individual again, and the family $16,300. 3 in 4 of Americans live paycheck to paycheck. 2 in 3 Americans don't have $500 to cover an emergency. And this is where then you put COVID on top of this, and you have a complete catastrophic disaster, truly. And if you would go to the next slide, Sarah, please. So I want to bring this point up on this slide because what we hear proponents of these plans saying is, well, if a member's in a high deductible health plan, then they would put money in their HSA pre-tax and they have no problem. Well, again, if we lived in a perfect world and every American could afford to put the maximum amount in their HSA every year, the maximum amount you can put in your HSA your actual savings contribution is only $3,550 for an individual, but the max out of pocket is $8,150, far short of that. And you cannot take money out of an HSA that isn't saved. So in April, when they need that whole value of to be able to get their drug, or they can't get it, they're left without it, they don't have that money saved if they started saving in January. But again, it would be far short anyway. And then let's look at the COVID numbers in Michigan. And Michigan is one of the highest states as far as loss of employment. The latest data that I was able to pull up today shows a change in number of jobs from February to July. You see here on the screen, and the percent of job change is minus 11.7%. So when somebody loses employer-sponsored or loses employment and then loses their employer-sponsored insurance, they're left in Michigan. You are an expanded Medicaid state, so a patient would have the option to get on Medicaid if they were income eligible, or they're going to go on the marketplace. And the chances are they're going to choose a plan on the marketplace that is going to be a low premium, as low as they can get, right? Because money's an issue. And so, but a low premium means a higher out of pocket. And so it just exasperates the problem. And the next slide, if you would, Sarah, just shows also the impact of COVID. When we look at Kaiser put out at the end of May, the change of before and after COVID, employment, loss of employment sponsored insurance jobs. So again, a real catastrophic situation in our country. So we're going to get now to the real issue, which is, first of all, thank you, Representative, for trying to help pass some sort of legislation in Michigan. I've helped pass legislation in Virginia, which was the first state, and West Virginia shortly followed, Illinois, Arizona, and now Georgia, all have anti-accumulator bills. There's 3 different bill languages. The most inclusive as far as protection for patients would be Illinois, Virginia, and West Virginia, where they just ban accumulator adjustment programs, period. In Arizona, they say no accumulator adjustment programs if there's not a generic. If there is a generic, then they have to try the generic. And if there's a reason that didn't work and they meet the eligible, or they get the prior auth, then they can get the name brand. And of course, they couldn't use an accumulator. And then in Georgia, same, except that particular language takes a little bit even deeper dive, saying that plans don't have to accept the copay assistance, but if they do, then they can't put a copay accumulator on. So the fact of the matter is, these states are progressive in trying to affect change. Now more than ever, we need change. We need and we need it fast, because we have so many people reaching out going, I can't take my medication. And we have patient examples all over the country, and the truth is they're left with no other option when they can't take their medication and they have hemophilia. It's not that they can just stop taking their medicine. This isn't like an acne pill. This is life and death. So if they can't afford the medicine at the pharmacy counter, they're going to be left with no option but to go to the highest cost of care setting, which is the hospital or emergency room, to get an infusion. And that's the last place we want patients who are compromised already to be going during COVID. And it's going to cost the plan significantly more in the end, because of the cost of the infusions in those settings. So I'll stop there and answer any questions that anyone has. And I, again, thank you for your patience with this situation.
Thank you, Kollet. So that's definitely a complicated issue. So if our attendees on the line have any questions, I know maybe you're like, oh, wow, I don't even know really what to ask yet. That's fine. Let's give it a moment. But please, Kollet is here on the line. We finally got things worked out. So if you have questions, she's a really great person to ask. Or if you have any questions, I see that the representative is still on the line. Oh, Gwen did a great suggestion, which we can go back. And she said, what about a vocabulary overview? And I do know that I think we had some of that in Kollet's.
So vocabulary, I'm happy to, which vocabulary?
Let's go back to our key terms then.
Oh, yep, go back to key terms. Yep.
There we go.
So that's C. And that's,
and also,
you know,
could you maybe, Kollet, talk about, I know we talk about accumulator a lot, and just explain maybe what that is.
Yep. Sorry. So again, the key terms: premium is what you pay for your insurance. What you pay every month towards your premium does not count to your max out of pocket. That's the cost of getting your insurance. But then what does count to the max out of pocket, which is, again, as I mentioned, $8,150 in 2020, is your deductible, your copays, and your coinsurance accumulated together. Once they hit $8,150, then you've met your max and the plan kicks in and starts paying 100%. So an accumulator adjuster means that the plan will accept payments. That's, as we use this example, they accept the manufacturer assistance. They take the assistance, but they don't apply it towards your accumulator. They don't apply it towards the accumulated out-of-pocket for you. So you use the card for 3 months after it's exhausted, right? Because in my example I gave, it's $5,000 a month as your deductible. So if you have a $15,000 card, you've used it up in 3 months. Come April, and you know, if you didn't have an accumulator adjustment program on, they would have counted that in January. You would have met your deductible and you would have gone on and gotten taken care of without having any risk to non-adherence. But because of these programs, patients are left at that cliff, that moment in April, in my example, where they go, I don't have $5,000. I don't even have $500. And so that's where, because the insured took all the money from the manufacturer, but didn't count it towards your accumulated out-of-pocket. So an accumulator adjustment program means they adjust your accumulator to reflect only what you pay. They're no longer counting what somebody else pays on your behalf.
We do have another question, Kollet, and thank you for that. How would a patient know if they have a copay accumulator attached to their plan?
Well, that's the other problem. It's so convoluted. Sometimes we find it on page 72 of someone's health plan, and it's buried in language such as, I'll give you an example. I believe United Healthcare is true out-of-pocket benefit protection program. Now, I know nobody who thinks that that's a bad thing. That sounds good. They're giving me benefit out-of-pocket protection, right? So they're calling these programs names that are very confusing, on top of the fact that the general Q public doesn't even understand the basic 4 terms. So they're certainly not going to understand the implications. You can do a search if you have a digital copy, electronic copy of your plan. I would recommend do like a search find and try to look for out of pocket, look for copay, look for accumulator, look for any of those words. And we're happy to help as well. And, you know, if you're confused by that, but certainly as open enrollment is going to come up, more and more plans are switching to these programs. It's a money generator for the health plans, because they collected, in the case I just showed you, they collected $5,000 January, $5,000 February, $5,000 March, and now if the patient had the $5,000, they would have collected it again in April. So they collected $20,000 for a patient's $5,000 deductible.
Yes. So thank you for that. We do have some more questions coming in. Thank you, everyone. And a reminder.
We know they're in Michigan on the marketplace. I mean, we've done a scour, like I helped start the All Copays Count Coalition. It's a national coalition. We have 86 member organizations now. And we've been scouring plans across the country, and we know Michigan plans do have them. And that's, again, where we run into risk with COVID, because if people are forced to go onto the marketplace now because they lose employer coverage, they're going to be looking at the lowest premium because of the financial constraints. And the lower the premium, the higher the out-of-pocket, the bigger the risk.
We have many more questions coming in, so I love how everyone's really invested in this. We have a question here. So I'm quoting, "So to me, this is double dipping by the enemy. How is this legal? As an individual, I can pay my niece's hospital bill. Why is this any different?"
Well, it's actually, in my example, it's quadruple dipping, but let's not mince words. It seems wrong. That's why everybody didn't believe me when I first recognized this language in 2016 on the first health plan, because it doesn't seem legal. But the fact of the matter is, the health plan uses the fact that when it says you're out of pocket, they mean you're out of pocket, not somebody else paying it. But listen, if grandma pays your out of pocket, or aunt or uncle or parents. I mean, I don't understand. It's no different cost to the insurer. I could see if we're talking about $5 Crestor example that I gave you, where if I use this coupon, I get to take a name brand at the same price as the generic, and on the back end, it costs my health plan more. I understand that. That's not what these are targeting. These are targeting specialty drugs, the majority of which do not have a generic, and these assistance dollars are available for every drug that's on the market for hemophilia. So it's not pushing patients to one drug to another. It's just simply an excuse. It is not absolutely a fact.
Mm-hmm. Thank you. We have another question that I think I'm understanding correctly, is asking if we have a prohibition on not being able to use Drugmaker assistance. So I think they're asking if it's illegal to use manufacturer copay assistance, which I can answer, it is not. Kollet, if you want to share a bit about maybe the recent CMS ruling and talking about where this is legal and allowed and where it's not.
Right. Well, so yeah, we had some success last year working with CMS and CSIO to get the NBPP 2020, which stands for National Benefit and Payment Parameters, which was actually guidance for all health plans, including ERISA plans, which is self-funded employer plans. And it said no accumulator adjustment programs if there's not a generic. It was a short-lived victory. 3 months later, they walked it back because the proponents of accumulators jumped up and down, and they said, but hang on, you know, these accumulator adjustment programs are a violation of IRS HSA guidelines. If you put money in HSA, you have to spend it on your health plan. Well, I don't know anybody who doesn't have other healthcare costs. You can use it on braces, on eyeglasses, you know, et cetera. I mean, you have other kids, you have other family, you're going to have the expenses. And so that was a very big disappointment and a setback. And when the 2021 language came out, because we also met with OMB and the Department of Labor to try to get them to reinstate the original NBPP language. And they ended up coming out with, you can put an accumulator on if you want to, you know, so not banning them. And to me, that answers the IRS question, because if it was a violation, they wouldn't say you could put one or you don't have to. And, you know, I can give examples. I use St. Jude. We see commercials every day. If you come here, it doesn't matter if you have insurance or not, they'll collect what your insurance pays and you don't pay anything else. No family gets a bill. What if you have an HSA? I mean, it just doesn't make sense.
And so to follow up to their question, it is not illegal anywhere to use manufacturer copay assistance. It's just determining whether or not it counts towards your accumulator. Well,
if you're saying anywhere, Medicare does not allow manufacturer copay assistance to be used to get a patient out the donut hole. However, they can use third-party nonprofit assistance, and they do count that towards the members out of pocket.
Thank you for clarifying that. We have another question here. How does your insurance company know who pays for the drug? My specialty pharmacy gets payment, right? How does the insurance company know who pays the cost?
Well, it's actually the PBMs, the pharmacy benefit managers, and the specialty pharmacies that promoted this to begin with, not the health plans. So let me clarify that. And so the original intent when they came up with this idea was, but if I sell it to you, the health plan, and I sell it to you, the employer, I sell it like this. We can identify when payments are made on behalf of a member, not by the member, and we will not apply that to the member's accumulator. But in order to do that, we have to have an exclusive contract to our wholly owned specialty pharmacy, our wholly owned nonprofit, or our wholly owned for-profit specialty pharmacy. Again, another gimmick to try to get exclusivity with their contracts. It's a conflict, frankly. And so that's how they identify it. But the fact of the matter is, then if the member couldn't afford their pharmacy or their medications, then that specialty pharmacy would lose the revenue. So guess what? I'm on calls all the time trying to help patients, and those specialty pharmacies on the back end are saying, let us try to help you circumvent this. It's really it's sad just how convoluted the situation is, and it's putting patients smack dab in the middle.
Right. And just to clarify, Kollet, this is not a discount on a drug.
No.
It is copay assistance.
Correct. has nothing to do with the cost. In fact, it increases the cost for members because you have to pay list price until you meet your deductible. As a patient, you have to pay the cash price up until your deductible is paid. Your health plan has a contracted rate. You don't get that rate. So if anything, it's not a discount at all.
Mm-hmm. We do have a couple more questions, and we seem to have some time. So can these be implemented at any time during the plan year or just during open enrollment?
Sadly, they've been implemented during the plan year. They're supposed to be, just like you can't change your plan during the plan year. I don't know how they're able to do it, but we've seen them implemented in the middle of the plan year. Now, we've had some plans say the language was already in there. We just didn't enforce it, but now we are. So, sadly,
and to follow up onto that, I had someone ask, how do they check a marketplace plan for this? And I know that you mentioned earlier a few keywords that you can put into a search. So let's share some of those again, like deductible, out-of-pocket cost.
First of all, remember two things. Be cautious, and you need to educate your community, because if they lost employer-sponsored coverage and they go onto the marketplace, the first thing they're going to look is for the cheapest premium. Well, today, because we aren't enforcing ACA, we have skinny plans on the marketplace, which means they aren't going to get coverage for their pre-existing conditions or their drugs. And and patients are unaware until they've already picked the plan. Unfortunately, my daughter herself got suckered into one of those last year. But then the next option, hopefully that you educate them on that. They don't choose a skinny plan. The next thing is they're likely going to choose a high deductible health plan, because the lower the premium, the lower the cost of the plan, the higher the out-of-pocket. So they're going to choose a lower premium, but then they're going to be in a high deductible plan, and the majority of high deductible health plans are implementing these copay accumulators.
I have another question.
But doing the search, so if you can get a hold of an electronic copy, and this is hard to do, it's not always easy, but if you can get, because they say, well, once you choose the plan, we'll send you the language. But if you can get a hold of an electronic copy of the plan, or if you have employer and it's open enrollment and you get a hold of the plans, then I would do a search by copay, out of pocket, accumulator. Those are the kind of keywords I would look for.
Great. So I have another question here, which I think we can just clarify. Someone said, why would the specialty pharmacy want this? So it's the pharmacy benefit managers you mentioned that introduced this idea. And then the question is, why aren't the pharmaceutical companies fighting this?
Oh, they're fighting it. I mean, you better believe they're fighting it, but I know we have a pharmaceutical company online. I get why they'd fight it. But we're fighting it because it risks patient access. That's our start and stop for this whole issue. We don't have any other skin in the game other than to make sure our patients have access to life and death medications. And specialty pharmacies today, unfortunately, most of the big health plans now own the PBMs, and they own their own specialty pharmacy. And so they're inherently conflicted in that way anyway. And it's hugely a monopolistic environment. And that's why they want them to get the exclusivity.
What should a person do when they find out their plan is using an accumulator adjuster program?
Well, we've been able to affect change by, if it's an employer plan, if it's self-funded, we can help with talking to the employer. We've had employers reverse the plans. We've had some employers move the hemophilia drugs onto the preventative drug list, which means it's first dollar coverage for those drugs so that they don't run into this risk. But the fact is, some of sadly, the unintended consequences, as I mentioned, when patients are left, like in my example in April, with no way to get their medication, we have the worst example to date is a young man who was just out of college who could not afford the $6,500. And I took 40 days trying to help him get this taken care of. And he refused to use credit cards because he said he had no way to pay them back. And so long story short, in the meantime, he was having multiple internal bleeds in his colon, but also in his knee and hip. And those bleeds went untreated and became target joints, which, if you know anything about hemophilia, then requires really high doses of medication, very costly. he went from costing the plan $86,000 for the 2 years leading up to, because he was just using as needed, and cost the plan $3.5 million in the next 2 years because of the results of these. So plans are finding out in a very hard way. The cost to them is excruciating as well.
Mm-hmm. Thank you. We have a question. Someone asked me if you could explain the scenario without the accumulator to compare the two again, if you could go into that.
Sure. So if you go back to that slide, are you still able to do that?
So
slide number 6.
I have scenario 2 with accumulator. Do you want me to be on that one?
Yep. So just for a minute, if this didn't have an accumulator, in January, when the patient called to get their medication, remember I told you it's $20,000. They have a $15,000 manufacturer assistance card. They would have called, asked for their meds. The pharmacy would have used the assistance card to pay the $5,000 deductible. And then at the bottom in that last row where you see patient remaining deductible amount, in January, that would have said 0, because that would have counted to their deductible, and their accumulator would have been met, and they would have been satisfied. So come February, March, April, May, the rest of the year, they would have been able to call, get their medicine with no risk. But because they aren't counting that to their accumulator, it keeps resetting the member's accumulator to reflect only what they paid. And in January, with an accumulator, they didn't pay anything themselves. Same with February, same with March. Does that make sense?
I think so. If you have any questions, of course, please continue asking them in the Q&A. Someone just clarified, with accumulator, total cost to patient is 0. And so
without accumulator, in that scenario, yeah, it would be nothing.
I think that there is also some confusion over how we're using the word accumulator. So when we say with accumulator, we mean with an accumulator adjuster, right? So
with an accumulator program. Sorry, actually my presentation I pulled this from, I show without anything, with an accumulator, with the maximizer, and then I show like the net cost to each party, but we were really trying to stay focused on this issue. And so I pulled those other slides out. So my apology.
Right. So to the community member who asked that, so with an accumulator, total cost of patient, they would have costs. It's without the accumulator that they would not have those costs.
Correct. I mean, well, they might, because listen, if they didn't need their medicine in January or February and they went to the doctor or the hospital, they're still going to have those charges, right? But if in a perfect world in January 1, they needed their meds, then it would technically have met their out-of-pocket. Listen, another option is going back to before ACA, we used to have a separate deductible for pharmacy as we did for medical. So, you know, I mean, when I talk to payers and I try to give them, you know, scenarios where that would be an option, is go back to that scenario. It's not the perfect world for patients. I mean, listen, patients with hemophilia and other lifelong chronic diseases, they suffer enough. This is year after year. Every year in January, they're going to be hit with these high costs. It's not something that's just a one-time deal. And, you know, I want to say, since we have a few minutes, one of the other things the proponents will argue is, well, it's not fair if, you know, John Doe has hemophilia and he gets to use this assistance to meet his out-of-pocket, but Jim Doe and George Doe and, you know, other cubicles in the company, they don't get that. And I say, well, you know, I'm George Doe or Jim Doe. I don't have hemophilia or a chronic disease, so I'm fortunate, knock on wood. And so if I ended up, God forbid, having something go wrong and I had to go to the hospital or ER, I would get treated and then I would get a bill. And my bill would be the contracted rate. If I had to pay my deductible in its entirety, I'm only going to pay on the contracted rate, not the billed rate. Whereas I told you with this thing, you're paying list price once you hit that cliff. So, and I'm going to pay it as I can. If I can't pay the whole thing, I'm going to send payments. And I still got treated. But with accumulator adjustment programs put on, once the patient hits that cliff, they're left at that moment. If they can't afford that $5,000 in April, they don't get their drug.
Mm-hmm. Right. I have another question. Thank you all for sharing so many of these questions. It's really great. Do any states require plans to share the language of contract before the consumer enters into the contract? Any of these states require consumer-friendly explanations of coverage by plans?
Yeah, we pushed for that when we met with CSIO and CMS. We have had some states push for that. The problem with that is that if they say you have to have the, excuse me, I'm sorry. If the plan has an accumulator language in it, and you make them put that real clear on the cover, this plan has an accumulator, and the member is gonna have to meet this entire cost, then the member is not going to choose that plan, right? They're all going to go for the plan that doesn't. But then that's going to bankrupt those plans if every one of the sickest patients choose that plan. So it's actually a conundrum that I don't know what the right answer for is. I prefer they just weren't allowed to do it.
Right. Okay, I'm just checking to see if we have any other questions. I don't see any other questions. I want to thank everyone for sticking around, and we know that issues happen all the time. We are just very happy that we did get to hear Kollet speak to us and explain this issue. Of course, it's complicated. If you all have any issues or any questions about this, please let us know. We'd be happy to pass those along. I'm going to share my screen just one more time for you all. I'd also like to share another thank you to Representative Frederick for joining us and staying on to hear about this topic. I think as patients and members of this community, we really appreciate when people take the time to listen. And so I'm really appreciative for that. I wanted to let you all know this is a treat for you. We're happy to treat you all to dinner during this program. Typically when we have educational events, we like to feed you all, and since we can't be sharing a meal together in person, HFM's happy to reimburse you for any carry out or delivery you ordered tonight. So if you can please take a photo of an itemized receipt and email it to Laura at lolson@hfmich.org. We'll be able to reimburse you up to $30, and please note that we're unable to reimburse for alcoholic purchases. And with that, I want to leave you with my name, Sarah Procario. I'm HFM's Advocacy Director, and you can feel free to call, email me. I'm happy to pass along any questions, to answer anything I'm able to. And also, I want to let you know that we'll continue to update the community on all the work that we're doing with Representative Frederick and seeing if we can really make sure that we protect you all from this issue and make sure that you can access your medication. So with that, I'm going to let you all go. Just under an hour. We did it. Have a wonderful evening, and we'll see you all soon. Bye, everyone.
Thank you so much. Bye-bye.